getting my readers out. Hey, it's going really fast. We're not, we just hit 70%, going to 75. Are you ready? I like to count down. 5, 4, 3, 2, 1, and close at 80%. Woohoo! There we go, guys. I hit share. Impressive. Nice.
21% looking for a medical coding career, 17% certified and looking for a job, 25% employed, 35% improve your current job situation and earn a new credential. Well, we want to hear and support you doing that. And just 1% is not pursuing employment at this time. Cool.
So 1% just wanted to come and see us. Thank you, 1%.
I'm going to leave that one alone for comment. I could get in trouble if I start freewheeling on that one. So congratulations for all those who have attended. We'd like to have you here. And here's our agenda that we have prepared for you. So Jennifer, tell us what you're going to be covering tonight.
Well, I can't see it yet, but I have a question about, somebody brought in about the non-face-to-face codes that we have, and as well as modifiers, preventive versus a diagnostic colonoscopy. We love talking about colonoscopies, and using anesthesia in the office. So,
yeah, I got fun ones. Strabismus surgery modifiers. We had a question come into our forum, and that was kind of exciting. I thought, you know what, this had some good stuff in it. So made that a nugget. IV infusion start and stop times. It's a little more in depth than that, the question, but ultimately that's what they were talking about. And class 2 obesity with comorbidities. How do you code that? Thank you guys for those questions. We had some really good ones come in.
Well, they're all coding this time.
Yeah. And you noticed
we didn't pick anything off of that topic. That's weird.
and I didn't like stick to ICD because those are CPT ones. I have to tell you, you pushed my comfort zone, guys, on those a little bit. I had to, I was like, oh. But anyway. So this is what we do, and this is our agenda. We go 60 to 90 minutes. We go over our prepared questions. We draw for the prizes because you stay to the end, and we take some questions from the chat, and it's not to stump us, but we'll look at some questions if you want to ask them, and kind of go over them after the webinar's over. And if there's something that we can't answer off the top of our heads, we'll turn it into a nugget and maybe add it to one of the webinars. You can ask questions anytime, but with GoToWebinar, like Boyd said earlier, we can see your questions, but you can't see our responses unless we hit respond, and then everybody can see your question and the response, okay? So we can't, you don't have to keep asking, did you see my question? Yeah, we've got Lori and Sylvia in the background going over the chats. And if you have a topic request, then go to cco.us/topic-request and feel free to add those. We'll do research and give you some, give a more in-depth explanation.
Feel free to challenge Alicia and
no.
Yeah, give them hard questions because they're bored, you know. They've been looking at these manuals for so long. They need a challenge every so often.
I pulled a manual out the other day. I was kind of moving stuff around the office, and I thought, well, it was sitting there. I thought, well, I'll just look that stuff up, and it's like, oh, wait, this was like a 2017. Well, no wonder it wasn't finding what I wanted. But anyway, don't forget to stay till the end, because we do give away a prize, and you have to have stayed through the webinar and stay till the end, and we will do a random drawing. We've got a program in the background that we can select the winner. We'll tell you more about that at the end. Make sure you go to the CCO Club. You can go to cco.us/club, and it is a great way to see all of the webinars that we do throughout the week. You know, there for a while, we were really packing in. We were doing new webinars for a course, and we were doing a couple webinars every day of the week practically. So now we do a minimum of 3 webinars a week live, and so you get to see that. You can see those in the replay areas. We have the Q&A questions where you can ask questions in the forum, and we have a lot of extended product support. So if you want CEUs, or if you just want that extra training and a nice community area, then absolutely, that's where you want to be. We always talk about our graduates at our public Q&A webinar, and for August, we only have a couple slides of people graduating. But you know what? It's so exciting to, even when sometimes we've had like 5 and 6. So thank you guys for sharing with us when you do pass, especially when you use our products. We appreciate that. So we're going to go over those. If you recently passed, let us know in the chat so we can give you a shout out. But if you want to let us know, go to the cco.us/past -exam or hyphen or whatever you call that little doomahickey. Jennifer, do you want to go first and I'll do the second slide?
Sure. All right. So we have some CPCs and some CRCs that passed recently. So we have just very recently, yeah, within the past couple of weeks. So we have Sandra M, who passed her CPC, and Sandra R, who passed her CPC using some of our products. Jareen Wiggins was a CPC recent graduate, and Carrie G is a CRC recent graduate.
Thank you. And oh no, that can't be right. XXX did a really good job. You know what? Those look like they're older. I think that might have been a mistake. So if we didn't, you know what? We'll get you on the next one. But congratulations to XXXXX. Man, you're doing great.
That's the secret agent that I didn't tell you guys about. That
knocked out the CB. You know what? Now that I think about it, I think Mary sent us a note and said we only have 1 page of graduates, which is yeah, we haven't had that in a long time. So this is the template page I think she uses because it's got all these credentials. But otherwise, we'll just kudos to XXX. Wow.
XXX could be today's winner then. Yay.
Yeah.
It's actually an auditor who's trying to do stuff under the radar.
Oh, okay. Yeah.
Right. So here we go on to the Q&A for August 2019. And I believe Jennifer's first up. If I remember correctly when I was putting the slides together.
Yeah.
All right. Me too.
All right. We somebody just had some questions, and their question really is just asking for some more information, and we're happy to do that too. So you don't always have to say what's the answer to this question. This person wanted just some more information. So they're dealing with non-face-to-face non-physicians, so wondering about some of those CPT codes as well as kind of modifiers in general. So I started out with, modifiers can be pretty tricky. We do have many videos talking about modifiers if that's an area that you're not dealing very well with, if you kind of forget them or trying to look at, certain circumstances to use them, because there are many modifiers out there. You look at the front of the HCPCS book and you got that double folded open up page of your HCPCS. Those are all modifiers and CPT modifiers. So there's many of them out there and they're all for different circumstances. So you have such like anesthesia and DME and billing. So we've got like our Medicare waivers and things like that are all modifiers. So in a general assessment, because these face-to-face codes were coming from the E&M section, and there's a few in the medicine section, I kind of just said, pretty much what you're looking at is the E&M modifiers. There's only 3. So that those are the main 3 to remember, because in an office setting, pretty much everybody's going to have an E&M code, depending upon what type of specialty it is. But the E&Ms are very important, and I don't know how often I see a claim coming in with 99214 RT for right. Well, no, you can't put that on an E&M. There's only 3 modifiers, such as a 24, which is an unrelated evaluation and management during a postoperative period performed by the same physician who did the operative surgical procedure. 25, very, very ever important, 25, the significant and separately identifiable E&M. So something totally different on the same day as a procedure by the same physician performing the procedure, as well as 57, your decision for surgery, which is very important. A lot of times people don't understand that some of those, we learn CPT codes, but there's actually a global period attached to CPT codes. So there's possibly a 10-day period or 90-day period where you can't have an evaluation of management during that period. Well, that which counts as the day before, day of, and 90 days after. So day before, you do an E&M, or the day of, you do an E&M, but that day was your decision for surgery. So those are 3 extremely important modifiers, and they're only used on an evaluation management code, 99201 through 99215. That's when you're using them, and you're inpatient and things like that. So any other modifier you use is going to be appended to a CPT procedure code. So 59, 79, 78, 91, anything else you're going to use is going to go along with a different code from the CPT section. So non-face-to-face physician services, some of those include your prolonged services, your interprofessional consultations, and your remote or your vital services. So there's actually codes that we can bill when the physician didn't see the patient. So you may not use them very often. It depends on what field you're working in. So the first is our prolonged services. We've heard about these. These are everyone that the physician wants because I spent an extra time with that patient. Well, it has to be documented. You can also have a non-face-to-face prolonged service, which of course physicians would like to use those too. So our example, you have a developmental specialist who's going to be seeing a patient as a new patient. So they have records from their previous providers, counselors, psychologists, school personnel. They may have all of these records that they're reviewing before they see the patient. They want to get a good history and a good feel for this patient. And then after they evaluate the patient, they need to write a report and send it back to that physician, that counselor, that school personnel. So they're going to bill an E&M charge for whatever service they provided that day. And they can also bill a prolonged evaluation non-face-to-face, a 99358. So they were doing a prolonged evaluation management service before and or after their direct patient care for the first hour. Well, that's 30 to 74 minutes. That's not an hour, but that's how they equate time and hour periods. Time is always a little bit different in CPT, and they break that down quite often. So all the time it took them to review those records, write that report, that was non-face-to-face. The patient wasn't there. They weren't in the room. They're able to bill this as well, in addition to what they did. Of course, this all requires documentation. So being able to document that they did that. Another non-face-to-face is our interprofessional consultations. So we have our patient's treating physician needs the opinion of somebody else or a specialist, or one specialist needs to speak to another specialist. So where I'm at, I work with orthopedics. We have a lot of specialists. Well, what if there's a specific procedure that somebody needs done that only a orthopedic in Boston does? Well, they might need to do a consultation. So that's an interprofessional consultation. And these are all based upon time. So there's more than this 99446 code. Just to shorten some of these answer sheets, I only included one, but that's 5 to 10 minutes. So you understand that the other ones are going to be more than that. You have another time frame available. So it's either via the phone or the internet or some kind of EHR assessment. If I work for also a large corporation, and once we all are integrated on the same EHR, our physicians in Richmond will be able to see what a physician in Pittsburgh is doing and be able to consult those medical records. So they could get a different opinion from a specialist in orthopedics, which we do have those two fellows who deal specifically with a particular body part. We have our remote and virtual services. This is not our telehealth service. This is using monitoring devices remotely. You may have heard how, you just dial in your pacemaker and the physician can assess that. So this is similar to that. So one example is 99091, the collection and interpretation of physiologic data, such as, there's more examples, but one was glucose monitoring. And it's digitally stored and/or it's transmitted by the patient or their caregiver to the physician. And it requires a minimum of 30 minutes of time every 30 days. So they're reviewing this documentation, they're seeing their glucose level, so they get to bill for that. They didn't see the patient. They're reviewing the data in order to make sure that that patient's health is progressing the way it should be. So there are other non-face-to-face services mentioned that include telephone services. So this is, and these get to be very important here when we talk about these telephone services. So 99441 is just one of the examples. Again, they change dependent upon the minutes. This is a telephone evaluation and management done by a physician who may report that service that they provided to an established patient. It has to be established. Remember, a physician's never going to assess a brand new patient over the phone. They need to see them for that. So this is an established patient, somebody they have a rapport with for a related E&M service provided within the previous 7 days, nor is it leading to an E&M service within the next 24 hours or the soonest available appointment. So I have an example. A patient calls their pediatrician with concerns stemming from a visit 10 days ago. So say they were there, they were given an antibiotic and they said, take this for 10 days. When the mom's going, oh my gosh, it isn't working. It's been 10 days and it's still there. Well, if that physician were to feel that those symptoms, well, yeah, that's typical. They're going to linger. If you still have problems next week, come in. So if they're reviewing this information, they're talking about the signs and symptoms for a 5 to 10 minute phone call, it can be documented and this physician can bill for that for the patient without actually seeing them face to face. But if they said, oh my gosh, you need to come in here tomorrow, get in here, they can't bill for it because it's leading to a service within the next 24 hours, or say it's Friday, or the soonest available, which would be Monday, if they don't work weekends. So that's what they're looking at. If it equated anything within the last 7 days, or they're going to have them come up for a follow-up. They don't bill for it because they're going to use that information from that phone call they just had as part of their evaluation and management when they do see them. So they can't bill for it extra. So that's why I used an example of 10-day, antibiotic prescription. Finally, we have an online medical evaluation. So this service is an online inquiry requiring a timely response. Now, it needs to be determined within your office what's considered a timely response. Say you have a physician who does surgeries a couple days a week in a hospital. That timely response can't come in 24 hours. It needs to come in maybe 48 hours. And permanent storage of that encounter. So it needs to be information that's documented and stored. If it's an online inquiry, it needs to be able to be attached to the EHR system perhaps, and it only reported once every 7 days. If it's in relation to that E&M service, then it can't be billed. It will be included as part of that. If they're just saying, oh, I forgot to tell you that I'm taking Tylenol already. Oh, okay, well, that's good. They don't need to report that. It just goes along with that E&M that they already billed. So one example is 99444, an online E&M provided by a physician or other qualified healthcare professional. who can report E&M services. So we all know not everybody can report E&M services, right? So we need to carefully review the rules of each of these services, and they're all outlined in CPT, because a lot of them say if it's going to be if you're going to come back and be seen in an additional amount of time or a certain amount of time. Some of the codes were 14 days for that interprofessional consultation. Say you called that doctor in Boston and said, I need to get my patient in there. If they're going to come in the next 14 days, then they don't bill for that because they're going to be seen. And also insurance carriers might have their own guidelines, or they may not pay for it. It's possible that there is no reimbursement policy available for telephone services with Aetna, for example. You know, maybe they just don't even pay them, which we still report them for the statistical reason. We want to let them know this is how we do business. This is what's done to treat this patient. And so we may not get paid for it, but we're still going to report it because they might have to make a change in their guidelines then. Wow, we received 200 of these claims in for patients, we might have to start paying for them. Now, there are non-face-to-face, non-physician services, which come up with a varied definition. So according to Medicare, an other qualified healthcare professional is defined as your anesthesiologist assistant, a midwife, a nurse anesthetist, a nurse practitioner, physician assistant. There's a lot of different terms that they use for a other qualified healthcare professional. The CPT says a non-physician is a physical or occupational or speech therapist or a registered dietitian. So there's a little bit of variance there. So it kind of, when you talk about non-face-to-face, non-physician services, that's a CPT definition. So they're talking about your physical, speech, occupational therapists, and your dietitians. So the services are not your office staff, the receptionist, a medical assistant, a technician, and they have to be clinical of nature. They're not calling to discuss something else or some concern or their medical bill. We don't bill for that. It has to be a clinical concern. So the I've found the American Academy of Pediatrics, they did contact in 2009, they contacted CPT and said, okay, we need some clarification here because their clinical staff can report that a registered nurse, they can use that code if, then they have to meet all criteria. So if it falls within your state practice law for that scope of practice for a registered nurse, an established patient protocol, you have a protocol established in your office that this is what we always do. The physician is going to assume responsibility then for what has just been relayed to that patient. And the patient must be established. Again, you can't do a new patient. And all the charges have to originate from that physician's office. It can't go through some outsourced call center. So if it meets all 5 of those criteria, then yes, even a registered nurse could be considered to be able to bill this. And so then I just have those 2 other codes. They're in the medicine section. Again, telephone services and online medical evaluations, the same as were just described previously, except it's a code for a non-physician. So there's different terminology, depends on who you're billing it to and who you're talking about. Rather interesting. I did a whole bunch of evaluations today online. I can't remember if it's in this answer sheet or the next one that I included it. Oh, there it is. Yep. The proposed rules for 2020. This link, it's an 808-page document. So if you're totally bored one night and you can't sleep and you want something to read, review this. These are the proposed changes for CMS for 2020. And in them, one of them is the state's scope. So we know a lot of physician assistants can't bill for particular services with Medicare, but now that might change. So read what they have to say about it, see if it affects your state, and see then if that's something that possibly in the future you might be able to bill for instead of an incident to service. So I just thought I'd provide that. It is rather interesting. I only got through maybe 80 pages of it, so 1/10 of it.
I like a little light reading.
Oh, yeah.
I say that that all the time.
And it's like your proper English. And hitherto then we say,
Oh,
we agree that, yeah.
uh,
So,
oh, hey guys, we have a back to school sale because everybody's going back to school. Last week, our local people went to school. Oh no, it was this week. It was this week that they went back to school, and different people, different areas of the states start. So again, back to school sale, you can get 25% off of courses and blitzes. Not always are the blitzes included. If you want more information, you can go to the cco.us/BTS for back to school sale, then hyphen 2019. It's going to expire Friday, the 23rd at midnight. So take advantage of the sale. My husband says that's a 4-letter word. He hates hearing that word. Oh well. So I get to go next. The question that came in was on strabismus surgery modifiers. And the person had asked is that when coding 2 horizontal extraocular muscles, one right and one left, which is the proper way to code it? Are we going to use 67311 right and 67311 left? Or are we going to do the same thing, write the code once, 67311 with the modifier 50, which is for laterality, or is both variations acceptable? Same for vertical, which is just a different code, the 67314, right and left. And thanks in advance. So, you know, this was a really good question because we did have a lot of other conversations off of this in our forum. And I thought, you know what, this is a good one to put out there for our public webinar. And the fact is, let me just scroll down here. You can use both. It doesn't matter. Now, for the most part, I think you're not going to see the code written twice with the modifier right and left. You're going to see the modifier 50 put on there, but know that it really depends on what your payer wants. So it's kind of like the whole tomato. It just depends. But for the most part, it's probably going to be the modifier 50. It's easier to put one code on there with that modifier than to repeat the code. I did find this in the CPT Assistant Archives for 2017. And I left this small because I have a lot of information on here. It says the patient had surgery for bilateral rectus resection, a 5 millimeter with tendon, et cetera, et cetera. That really isn't the pertinent stuff. Is that does the code 68110, sorry, I'm getting buzzed by a fly, excision of lesion conjunctiva up to 1 centimeter, completely describe this procedure? And then the person goes on to say no, and then it says with modifier 50 appended if they do this on both of the eyes. So just to kind of give you a little additional information for your knowledge base, I went ahead and took the code, the 67311. This is strabismus surgery, and it's a recession or resection procedure, one horizontal muscle. And I put a graphic in here so that you could see it and how they actually do that. The extraocular muscles is what controls the eye movement. Sometimes it's too long, sometimes it's too short, and so therefore you get the eye turning in and out. They can usually recognize this in a child pretty early. Sometimes the muscle's too weak and versus too strong or tight, and so they can go in and just adjust that quickly. I thought you might like to know extraocular is the muscles too strong or it's too tight. So they do a recession of the affected eye. Okay, so if both eyes are affected, they'll do both eyes. If they do an extraocular muscle when it's too weak, they do a recession on the opposing eye, which is interesting, right? So then it goes on to tell you about how they do that, and I pulled this straight from Find a Code, which is kind of nice to have all of that extra information in there. I'm not going to read this for you. It's mostly in there for you to look at. So if you're in our club, you're able to get these answer sheets and look at them about how they actually do it. But wanted to show you this great picture that I found, and it shows you where the superior oblique muscle is, the superior rectus, the medial rectus, there's that lateral rectus on the side, and then you have the inferior oblique and inferior rectus. So it kind of gives you an idea when you see that, how it pulls the eye, the muscle around the eye. So if you're going to use these codes 67311, you're doing a recession or resection, and it's either the lateral or the medial rectal muscle. So here's the lateral, and the medial is right here on that, if you can see down in behind there. And then the 67312 is you're going to do both the lateral and the medial rectus muscle of the same eye. Okay. And then 67314, we're going to do either the superior or inferior rectus muscle. So here's that inferior rectus muscle kind of wraps around, and then that superior is right here. There's superior oblique and superior rectus muscle right there. And then it goes on to 67316, where you're going to do the same thing, but it's of the same eye. So I thought it was kind of neat if you could see the codes and relate them to the muscle. It makes it easier to code these when you understand what's going on and you can see that. So the answer to the question ultimately is yes. You can do it either way, but the payer is the one that's going to make that decision for you. Give them I should say, give them a shout out, send them an email. We used to call them, but we don't call anymore. We just send them an email and see which they prefer, or you can just probably go online, but it's probably going to be modifier 50. It's just easier to do it that way. Nice, easy one. All right, I kind of feel a poll coming on. Yep. Which area do you feel a need for more education? And you know what? We really appreciate this poll, so please take some time to answer that. It helps us know what you're looking for. We do these webinars for you. We do them free, and hopefully it's content that's pertinent to what you're needing, either as a student or as a person that's about to test, or maybe you've recently tested and you just want to bring your skill, your knowledge up, or maybe you've been out there for a while and you want to get into something new, like working on rectus muscles of the eyeball. Or you want to know how to spell strabismus. Now you know. Okay, so we're only at 47, 50%. I hope that you're not getting too tired. We've got some really great content coming up, and we're at 60%. Maybe you guys are a little undecided. I'm going to go ahead and close the poll. We're right at 70. Here we go. 5, 4, 3, 2, 1, and we're at 68. Come on. 70. Come on. Oh, I did it. Sorry. Drag that out. That was me. So I'm looking here on my alternate screen, and it says, wow, 25% want more in billing, which is tickling Jennifer's ears because that's her specialty, right? She's really enjoys the billing. 33% on CPT, which is not unusual because, you guys, most of the coding exams for a general coding, like the CCSP or the CPC, is CPT knowledge. Only 14% of you guys want ICD. That's my favorite, guys. Then we have specialty credentials. Make sure you give us a little shout out and let us know which credential you're looking for. 15% and 13%, which is just other. So thank you. We're kind of working on getting a curriculum out for mental health. So if that's something that you're interested in, let us know. Jesus and I are looking at a couple books to use for texts. And
yeah. In our chats, we had the COC, RA, CRC, and Path Lab. So
you guys, we have an excellent pathophysiology course. So yeah, that's one it's great. And our Mary, who is a nurse, is the instructor for that. Oh, it's Jennifer's turn again.
Yay. Well, we had somebody who was wondering about preventive and diagnostic colonoscopies. So there are certain rules that you follow when we're dealing with the colonoscopy. So now we all are familiar with the nice little chart that's put in the CPT manual, which is very beneficial. Tag it, flag it somehow in your CPT book. So if you're studying, you can go straight to that because you know it will come up. But that is how to code specifically that colonoscopy if it doesn't get to a certain point, or if it did get to a certain point, what code is it? What do you use for modifiers and such? So anyways, this person just needed some clarification for outpatient hospital procedure. So a preventive, they know that that's, you know, the doctor, they're documenting the H&P, the patient has no symptoms. And so they said, okay, we'll do a screening. Okay, that's preventive. Diagnostic, okay, there's something documented that says they have blood in the stool or something like that. So, okay, we need to go in there. This is diagnostic. We need to diagnose it and look at it and see what's wrong. That's diagnostic. Okay. So what if they say the patient has rectal bleeding, but the treatment plan is to do a screening with a screening ICD-10 code as their diagnosis. So, so the case wound up being coded with 45380 with a 33 modifier, and we're going to go over all this. And their diagnosis was the screening. But their question is, well, if the doctor said there was a problem, they had rectal bleeding, why is it a screening? So should it be diagnostic or should it be the preventive screening? So we're going to kind of break this down a little bit. According to the American Gastroenterological Association, so the screening test is provided when that patient has no signs or symptoms. So, okay, you're 58, time for colonoscopy. You're not having any problems, so probably everything's okay, but we need to do it. So we're looking at the screening then. We want to make sure there's no problems. We're screening the patient to see if there's anything wrong. So even if they found a polyp or some kind of benign or malignant or some kind of cancer in there, some kind of problem that they found during that test, the intent doesn't change. It started as a screening. That's the codes we're going to use even though we found something while we were there. So the screening diagnosis is still going to be primary, and then that polyp or whatever is going to be secondary. So a diagnostic is performed according to the AGA when there's an abnormal finding, a sign, or a symptom. It could be abdominal pain. It could be bleeding or diarrhea. Anemia is another reason why they would do a diagnostic colonoscopy. So on their website of AGA, they had some commonly asked questions and answers. So I thought, okay, I'm going to snag one of these. What if the patient or their referring physician who called and said, okay, I need to get this patient in for a colonoscopy. They said, yep, they have no symptoms. Or you talk to the patient, they said, yeah, I have no symptoms. But then they come into the office and they say, well, yeah, but I had problems in the past, but I don't have any now. So that at that point, it becomes the physician's decision. If those symptoms or whatever they had in the past or what might have gone on previously is going to justify whether they are going to do a screening or a diagnostic procedure. So that's a little tricky, and that's the physician who's going to make that decision once they're there talking to the patient. What if they had polyps that were discovered on a past screening. However, when they come in now, they don't have symptoms. So that patient is asymptomatic, they don't have any symptoms, it's still considered a screening. Even though with the last time they had one 5 years ago or whatever, they said, yep, we found a problem, but it's okay, it's gonna go away or whatever. They don't have any symptoms or signs going on right now 5 years later. So it's again just a screening. So one reason why there's a big distinction between the diagnostic and the screening, why it's so important, is because of the Affordable Care Act. So when this came out, this was a mandate then that insurances for screenings, you're not going to make the patient responsible. So that was a very important part of it. The Affordable Care Act, we're trying to promote people to have good health. And how can they have good health and have all these screenings performed if we're going to make them pay for it? So this came out and said, okay, you're not subjected to your deductible. You don't have to pay those 20% co-insurance or something like that. Please go have this test done. So a lot of times what happens is the patient knows this and they call the doctor and they go, well, I'm not supposed to have a deductible. You billed it wrong. We love hearing that in the billing department. Right? You billed it wrong. And a lot of times they've already called the insurance company, and that might be what the insurance company's telling them too. Well, they billed it wrong. Well, not if the doctor found a problem. If the doctor found a problem, it's no longer screening, it's diagnostic. So that is something that the doctor should, or the staff should be explaining to the patient, is there's two different kinds. This will have some kind of patient responsibility. So screenings are usually billed with that diagnosis to indicate that it was screening, as well as a modifier. So they use modifier 33, preventive service. So we're trying remember, all of our codes that we send in are for statistical reasons. So this is letting them know the broad picture, the big picture going on here for the patient that day. They were screening, the intent is screening. Here's the modifier. This was a preventive service. Please don't bill them their deductible and their copays. So it's especially important with Medicare patients, because Medicare, of course, we know uses HCPCS codes for some of our services. And there are two different HCPCS codes. G0105 means that that patient had a screening, but they're at a high risk. So Medicare preventive services, if this is something you deal with, I would definitely search out their website, which is wonderful. It's a wonderful tool for preventive services. It tells you everything you need to know. So it will tell you they can only have these every 10 years. So unless they have problems. So a high-risk patient is considered somebody who had a close relative, their brother, their mom, who had the colorectal cancer, or an adenomatous polyp. I know I probably didn't say that right, but or a family history of hereditary non-polyposis cancer, personal history of polyps, a personal history of cancer that of course bumps you up to now you're higher risk. Even if you have inflammatory bowel disease, IBD, Crohn's disease, ulcerative colitis. So some of these things say, wait a minute, you're in a different category now, you get to have this service done more often, where the G0121 is the other HCPCS code we're going to use for screening for Medicare patients, and which is why this is so important to distinguish between what service we have that we're performing. These are people who don't have a high risk. So with that, we're going to bill that Z12.11, that encounter for screening for malignant neoplasm of the colon. But so the question that they gave, though, in the very beginning, and I brought it back down here again so we can remember what it was, is they coded it 45380 with a 33 modifier, the diagnosis of Z12.11. And so I just wanted to break this out a little bit more. Z1211 are encountered for screening malignant neoplasm. 45380 is a colonoscopy, flexural colonoscopy with biopsy. So they did something while they were in there. And we only have the one diagnosis of Z12.11. Now remember, it said that our intent doesn't change. We can build that Z code. If we really said this was screening, for some reason we just want to have another screening done, we did the screening diagnosis, we have the 33 modifier. But if we found something there because we did a biopsy, we need to have that second modifier in there indicating what we found. I'm not second modifier, second diagnosis, I'm sorry. But the diagnosis, it was intent for screening, however, something was done. But the H&P indicated rectal bleeding. So a query should be done. Sorry to draw this out. Bottom line, surprise, surprise, you have to query the provider. We need more information. If there was rectal bleeding, did this fall into that category that it's the provider's decision? Said, well, it could be rectal bleeding from some other reason, maybe a medication or maybe a digital rectal exam, who knows? But was it specifically continuous rectal bleeding or, whatever qualifications that physician determined would fall under a screening or a diagnostic. So some of the links that I included were some of the information that I got some of this information from regarding colonoscopy screening versus diagnostic. So we have to go back and ask the doctor. Nobody likes to do that.
No. That's when you bring them chocolate, right? You've got to bring them chocolate when you do that. Now, this is really good because it ends up being pertinent. Intent is very important. Always pay attention to intent. It's the intent of the procedure, whether you were able to do it or not. The same thing is like if you were planning to go to this part of the intestine and you didn't make it because there was a mass, you still code the intent of where you were trying to get to, add the modifier to say we weren't able to get there. So that was a lecture I got to go to here recently that was really.
Let me just throw this in here really quick. Somebody just asked a question, what about the PT modifier? PT modifier is used for Medicare, and most other carriers don't recognize the PT modifier. It is a Medicare modifier indicating it started as a screening and converted to diagnostic. So that's when you do the PT modifier is, okay, our intent was screening, we found something in there, we're adding the modifier to let there was something else in there. So
that's good too.
I'd do that real quick.
Good stuff. Ooh, okay. CCO reviews. Oh, Boyd goes in and he checks these reviews a lot. Do you want to tell about it, Boyd, since you popped back on there? Yay.
I do. Yeah, I'll get my 2 cents in. So a lot of people these days are always checking reviews to make sure that we are their organization that they're either buying education from or their local contractor or their plumber, in my particular case, or their fire suppression person is doing good business. Well, we have here at CCO.US an average rating of 5 stars with 653 reviews now over the course of when we started measuring all this stuff. And our 2 most recent ones that I selected here for you guys to take a look at tonight was on August 10th, 2019 by Jareen Wiggins, it looks like. And she submitted this at our CCO review page on CCO.US. And she said, yes, thanks to your program, I finally passed CPC exam on the third try. So what do you think about that, Alicia? That's
awesome. That tells me that she was able, you never discount somebody's education and what they've done, right? But she probably just couldn't put it all together, so she used some of our products and was able to put it all together. And we've had a lot of people say that they use the Blitz and oh wow, I finally understand all that stuff I studied for the past year. And so yeah, we see that. That's excellent.
What I like about that is that you always, if you fail once, you come back. Lisa failed on her first time. I know she's always talking about that, and here she is years later. Teaching us all. And the second review was on August 1st, 2019 by Sandra. Sandra didn't leave your last name, but it's still great. She said, I had taken a really good course at my community college and the AAPC practice exams, but still did not feel prepared for the exam. I discovered your website and the Blitz information on YouTube 1 week before my exam. Ooh,
Oh,
pretty close, right?
That's
yeah.
really close.
I blitzed through the Blitz. I've never heard that before. I blitzed through the Blitz and it brought it all together, which is what I needed. I am 99% sure I would not have passed without the information you provided, and especially the time management and the POE.
Yeah.
POE, for those of us who don't know what POE stands for.
Point of entry is what I use POE for. It's a medical term.
Got it. Okay. Thank you so much for
don't
being here. I wish everyone knew about you. So thank you so much, Sandra.
POE.
I'm trying
I
to
don't
think
know.
now.
POE, what goes with
Boy.
POE?
Yeah.
It could be anything, and we're not. Sorry, we're so dense, Sandra. But she's very right in that, like I said
Place
before,
of
she
employment?
went through her schooling. It was great schooling, but she had to bring it all together. And one of the things about the Blitz, which are on sale, it not only does it refresh you on what you've coded. I am shocked she was able to get her CPT manual done in a week. That's impressive. And then giving you tips on passing the exams, about time management and stuff. One person said she could hear Laureen sitting on her shoulder while she was taking the exam, and saying, do one column, and all the little tips that they give you in that. So thanks a lot, Sandra. That's great stuff.
Somebody
Hey,
thought
don't-
that maybe they mean the technique where you skip the hard questions, and
Maybe.
just one of the techniques that
Yeah.
techniques are different for everybody. So if you go to the easy ones first and then go back to the hard ones. Yeah.
You know what? I'm going to sit up in bed in the middle of the night. POE, of course, it means this. Now I feel really stupid. Sorry about that.
For me, POE means power over Ethernet. So
See, it's a point of entry when you're doing surgery and stuff. When now you know how our little
Edgar Allan Poe. I'm from Maryland, Baltimore area. It's Edgar Allan Poe. I'm sorry.
I was thinking too. My son loves Edgar Allan. It's Poe.
Pearls of expertise. Thank you, Whitney. Pearls of expertise.
Oh, yeah. There you go.
Oh, Whitney, thank you for joining us here.
See how we get nose blind to our own stuff? We're so used to seeing that stuff. So thank you. Thank you. Thank you. So we had some questions, a question come in about IV infusions, the start and stop times. First of all, I'm going to tell you there is a lot of content on the answer sheet that I did, and we're going to go over it quickly. But I could do a 2-hour lecture on the question that the person asked. So please, as we go through this, know that everybody in the club can come back and look at this. But an excellent question, and quite honestly, I didn't have enough information from the question to get the whole code, to code it out, because I didn't know the intent. Is it a hydration or versus a therapeutic, et cetera, which I'll talk about. But it's not easy to do infusions, and the start and stop times is a pertinent part of how you code for IV infusions, right? And then they wanted to know the ER versus having the person put in observation, and that puts a little crimp, and well, that's another whole set of things that we need to pay attention to. So this is going to be a launching point. I'll give you some information that will allow you to go and do some additional research to fine-tune something that maybe you want to learn about infusion. So the question came in and said that she had two questions. 96368 can only be allowed once per encounter, and that is true, okay? It is an add-on code, but you can only use it once an encounter. However, if there's a start and stop time, the last 3 hours, are you allowed to charge the 96366 times 2, meaning twice, along with 96368? Okay, now I've got an answer for that. and explaining what the codes are for. But the second question that came in was for this was, okay, if I have a patient that goes into the ER and they are doing a hydration infusion, so that means it's they're dehydrated, they're not getting additional medication. That's the purpose of the IV. It's not therapeutic, etc. They're not getting chemo, things like that. Hydration. And the code 96360 to start, and they have a stop, then is transferred to observation, which is a different status, right, in the facility, on the second day, and is given infusion med, okay, 96365, start and stop. Since there's only one initial, would you change the ER hydration to 96361 for day one and then leave the 96365 for the second day for observation, or leave both initial and add modifier 59? So first of all, when we're dealing with this question, know that both of the first codes, the first question, are add-on codes, all right? So the person who submitted this is saying, you know, we've got the initial code, but I want to use these add-on codes. Is this the proper way to do that? So if we look at the first one, the 96366, she said, okay, we're using 96366, and that's for the IV infusion for therapy or prophylaxis or diagnosis. But if you do that, you've got to, you know, make sure you, if you're infusing a drug or substance, you got to list that. So each additional hour, and you're going to list it separate from the primary procedure. Okay, so we're doing an IV infusion, and for whatever those three, one of the three reasons, but for that additional hour. And then it says, but I want to also use 96368, which ultimately is the same thing, except it's for a concurrent infusion. Okay, so now we have a code that we don't know which code that she picked, but we've got it. She wants to know, can we use an add-on code for that additional hour? And then would we be able to use the 96368 for a concurrent infusion? Okay, and so first, let me just show you the AMA, and I made this small because it was a lot of information that, you know, when you're dealing with these codes, because this is an add-on code, it says, hey, heads up, 96368 is only once per day of service. Okay, and that's ultimately what they were saying. You know, hey, I'm adding a concurrent infusion, but I can only use it once in the day. But we're going to be adding more drugs in. So how do I code that? And so again, that is just establishing, yes, she's right, you can only use it once per day. So let's break down some of these codes. If you're going to do that IV infusion and you tell them what the substance is that you're putting in, or a drug, is it going to be for therapy, prophylaxis, or diagnosis? You got to establish that first. It could be either one of those three. Now, they stated that we're doing it for hydration, okay, in the one question. So if we look at 96365, that's going to be the infusion for up to 1 hour. Okay, so that's like your first code, and then you can do add-on codes. Then you have the choice to add on 96366 for an additional hour of the same infusion. Okay, so this infusion is going to take 2 hours or 1 hour and 30 minutes. Then you're going to use your 96365, and then you can use your 96366. And then you also have 96367 for another sequential infusion of a different substance or a drug for up to 1 hour. Now, note, different substance. That's the key here. You know, the IV infusion is just going. It's ultimately just a line. We're hydrating the patient, but hey, by the way, we need to add potassium too, because now we got their labs back, they're low on potassium. We'll just go ahead and shoot them up with some potassium. Okay, then you also have the code that they mentioned was 6368 when you have a different substance, okay, and or drug, and it's administered at the same time as another drug in a concurrent infusion. So that means concurrent just means you're doing it at the same time, okay? So ultimately you're giving 2 meds at once. Now, it would have been really helpful if in her question, the little more information, if we knew what they were infusing concurrently, so that we could better understand, and also because it makes sense. If it's potassium, oh, okay, yeah, the disease process and the treatment. Now I understand what you're doing. That makes sense. Concurrent makes sense versus it being a sequential infusion, et cetera, because it's the way protocol says it's done. Okay, so now that you know what those codes are, and mind you, this is where I got some of this information, was from a coding clarification on facility reporting for the CPT assistant. Now, the first thing, let's back up. Hydration versus therapeutic infusion. Okay, if we're just hydrating the patient, there's some codes that we use for that, versus, hey, we're doing therapeutic, something therapeutically for the patient. And then this CPT assistant said, you got to understand that before you can move forward. So our codes for that is going to be 96360 and 96361 versus, and if you go in and you look at the codes that we just went over, which are for the when you go back up here, it's going to be therapy, prophylaxis, or diagnosis, okay, versus hydration. Now, real quick, if the purpose for the infusion is rehydration, okay, you're not giving them anything else, then the initial service, only hydration, then of course you're going to be able to use those codes. The 96360 is where you're going to start. Okay, but if the primary reason for the infusion was, say, hey, this person has low potassium, we're going to give them 20 milliequivalents of potassium, the KCI, if that is added to the IV, not because they're they could be dehydrated, but we're giving it because we need to give them potassium, that changes the ball game, right? So then we're going to go to those other codes where you get into that 96368 that she was talking about, which is an add-on code. And I've had that done before where I dehydrated myself and I didn't have enough potassium. And if you don't have enough potassium in your system, you can feel like you're having a heart attack. So they can either make you take potassium pills, but if they need to really, if they've already got an IV started, they can shoot it. Or do they start an IV because they want to give you IV potassium? And potassium burns like the dickens, by the way. So it's really hard on your vascular system too. So if they can make you take the pills, they will. Horse pills. So again, therapeutic, prophylactic, and diagnostic injections and infusion codes, there's our range. They are going to be for rapid or bolus infusions other than hydration. That's also key when you're looking at, why are we giving this? Are we doing a bolus, or are we doing this for just hydrating the patient? And it's usually done a slower, a slow hydration. Now, this is a question that came up that involved these codes. Now, this isn't the question the person asked. This came off the CPT assistant, and I thought it was pertinent, over that's a little bit different. So if you're going to use codes 96365 and 96368, and you're going to report them in the following scenario, it says, doesn't matter how long drug B is infused. So let's just say, we're not saying what drug B is. It's drug B. If it's following the 30 minutes of concurrent infusion. The patient is seen in the outpatient clinic for drug infusion. Okay, that's outpatient clinic versus facility, right? Drug A is administered at 6 a.m. and 7 to 7:30 p.m. So you've got an hour and 30 minutes. Drug B is administered through the same IV, because of course they're not going to open up, they're not going to start another IV. Now, there are reasons why with some medications and scenarios why they would have 2 IVs going at one time. Just know that that you say, well, of course you'd only use one IV. Why would you poke the person twice? Well, no, they actually do that sometimes and have IVs in 2 separate arms for various reasons. Okay, so you go the same intravenous line for 7 a.m. to 4 p.m. So these are interlapping, right? Because we started the one 6 o'clock and got done at 7:30, but then we gave them additional from 7 to 4. Okay, upon review of the infusion intervals, there's only a 30 minutes when both drugs were infused concurrently, because concurrently is the term. So what do we do? Okay, so then they're saying, yes, that's how you do it. But I thought that was pertinent for you to know that even though, so this is an hour and a half of an infusion, and then you code that the additional, you're going to specify the drug for the additional hour, et cetera, et cetera. Even the infusion interval did not exceed 30 minutes beyond the 1 hour increment. So the usage is stated as parenthetical instructions following the code 96366. So the 93666 has that parenthetical that tells you, and we all know what parenthetical stuff means. Okay, now, so 96368, intravenous infusion, we know what it's for. And if you have a concurrent infusion, you're going to list that separate additional to the primary procedure, and it could be reported once for the concurrent, which you would not based on time. 96368 is not a time-based add-on code. That's where the confusion gets. You know, it's not based on time, it's based on, hey, it's a concurrent push. Okay. So regardless of the duration of the infusion, that doesn't matter. Oh, well, it was only a 30-minute window when they were doing it concurrently. No, it's not based on time. Okay. And it's reported in addition to these codes that you can do it with. Okay. Now it says, by the way, the bulk of the time was spent administering the sequential infusion, right? Because it was 7:30 a.m. to 4. Okay, now that's pertinent. So you're going to end up being able to report 8 units of 96376. Okay, and it's not appropriate to report both the 96367 and the 96368. Okay, if the infusion that began concurrently and concluded sequentially. Okay, so again, this is a little background on how you do that and how you understand when it's concurrent. Okay, and again, the one being longer is pertinent. Now, time-based infusions, I went ahead and added this in there for facility reporting so that you could go back and look at it, but I'm not going to necessarily read this. What I want to do is show you the example. If you have the same drug is individually prepared, okay, so we're going to push the same drug, the same vascular access point, meaning the same IV, that's all that means, and over 1 hour each at 3 separate times, because that's kind of what this question above was saying. Hey, we did one in the ER and then we got them in observation, same IV, right? But we're giving them different drugs from the observation setting, with the third infusing commencing past midnight. So how do we code that? And this is the closest I could find to an example of what the person was asking. So you've got you need to know what's the purpose of the service of the procedure. So if you have a single calendar date, or is it a range of dates? So technically, we're going to say we have a range of dates. And if you're doing a single calendar date, then you can do the third infusion started after midnight, but you're not going to code the 96366, but you're going to code the 96365. Go back and look at the definition of that. Okay. Now it says, but if you have 2 doses prior to midnight, because midnight's your cutoff time, and you're going to report the codes with the 65 and the 66 respectively, and then any additional infusions with the IV site, that same IV site, then you would be coding off the hierarchy. Now, hierarchy, understand the hierarchy of all of this is another whole lecture, and you will see that term hierarchy when you talk about infusions. Research that on your own. Like I said, I could talk for an hour on this. So ultimately, though, some coding tips. Okay, if you're going to code over a range of dates, right now we're not talking whether the patient was ER versus observation. We're doing dates. And the initial infusion code, okay, we've got 6.5 there. You would not report for the dose administered after midnight. Instead, you're going to use the 6.6 code. So this is a term called keep open infusion. Right? You're not coding that separately. That's what I want you to go and do a little bit more research on as well. That term, keep open infusion. You're going to be able to Google it and find a lot of information. So you've got to ask yourself ultimately as we wrap this up, why are you why did they put in the IV? What was the purpose for the infusion? Is it going to be hydration? Is it going to be therapy? You know, and they get this all divided up. And then it says, what are you giving them? What's the drug? That's going to have to be coded. Okay. We're going to do a potassium push. Right. And then is it initial, sequential, or concurrent infusion? And this is the CPT assistant archive that had tons of information on it that expanded even more. So again, to answer the initial question, I hope I did that in there by giving the examples. However, really, there wasn't quite enough information to be able to tell you exactly how to code it. I don't almost have to see the infusion report. But this should be a launching point for you to know where your parameters are to be able to know if you're coding it accurately or not. Make sure you pay attention to keep open, and as well as that other thing I said. Let me just move it up here. This example here on how to code the choices, okay, in the hierarchy. Keep open and hierarchy. Those are the two things you want to do more research on. Okay, fun stuff, I know. And like I said, infusion is its own little game, not game, that kind of degrades it. It's a niche. And once you get it, it clicks for you, it's okay. But whew, it can be exciting learning. We have another poll. How many CCO webinars have you attended? Well, are you a first time? Whoop, whoop. We like to say that. Are we one time back for more? 2 to 5 repeat offender. If we're 5 to 10, you're liking it here, a CCO, or you're 10 plus, you're a CCO frequent flyer. And, oh, I didn't launch it. I'm sorry. Thank you. Whoops, there we go. Here, I'm just priding myself in doing so good. And then, you know, we do have some people like Whitney, and through the years we've had Patsy and some other people. They come to every webinar that we have. If you go to YouTube, and you can click on the little bell on Medical Coding Cert, and it'll ding when we have a webinar coming up live for you. So, wow, okay, now you're awake. So you're at 70%. So I'm gonna close. 5, 4, 3, 2, 1, and we're already at 75%. And so I've closed it and shared it. Wow, 23% of you guys are first time.
Awesome.
And 34% are 10 plus frequent flyers. 7%, only 7% coming back. So I hope you're coming back more often. 2 to 5 repeat offender, 22%, and 14% on 5 to 10. Thank you guys. Appreciate that. We have a lot of fun doing this. So if you haven't noticed, we do.
Oh yeah.
And anesthesia for the office. All right, I'll get off of here. And
I thought this question was rather interesting because it's orthopedics. This spoke to me, but we don't do anesthesia in our office. So I thought that was rather interesting to have an anesthesia in the office code. I'm sure there are facilities out there, whether they're they meet the definition to be an office, but yet they're included in some part of a ASC center or something like that, where they might have the ability to actually have an anesthesiologist in their office. Well, I don't have the answer sheet. Okay. So a 17-year-old patient came to the orthopedic office after falling off their skateboard. So this has to have just happened because he suffered a closed fracture of the left tib-fib, left tibia and fibula, as well as a severe sprain to the right wrist. So the patient was in severe pain. That's why I think it just happened. They're in so much pain. So the anesthesiologist administered anesthesia to him while the physician reduced the fracture. So it had to have just happened because that fracture needed to be put back together. The bones needed to be put back straight. And then they applied a cast to the lower leg. I thought that was rather interesting too, because typically right after a fracture, we don't apply a cast. You apply splint and do a cast a couple days later while you let the swelling go down. But, you know, everybody does their own thing. So their question was regarding the anesthesia code 01462 versus 01490. Is there a rule for which is it the procedure or the casting? So I talked a little bit earlier when we talk about these global fracture codes or these surgical codes, our 90-day global period. So the same thing falls for our fracture codes. Now, you didn't perform surgery on them, but that's how your bill is going to come back to the patient, and they're all going to say, I didn't have surgery, I broke my foot. Well, it's kind of all the same thing. But that orthopedic is going to submit a charge for the closed fracture of the left tib-fib. And that service is usually going to include it on that data service. When he sees this patient and bills a global charge, it's going to include a global procedures along with it. So all of the follow-up E&Ms for the next 90 days, they're part of that charge. We're anticipating seeing this patient again multiple times for this problem. That's why they get paid so much, because the work is involved continuing for 90 days. Casts on the first date. The first date of injury, the cast is included in that global surgical charge, that procedure code that we're going to bill. An injection to numb an area is included. This is a little bit different because we're giving anesthesia. We're not giving an injection. Sometimes they do that. They give an injection to numb the area before they try and put it back together. It just depends on the type of patient. Maybe they have some other conditions or something. So however, the service provided for anesthesia is being performed by another provider. Now, you'll know in some CPT codes, the physician cannot perform the anesthesia themselves. There are some codes that specifically say the anesthesia provided by the provider or anesthesia by somebody else, by an anesthesiologist. So they break some of those codes out. So it's possible that these two might be under the same tax ID number, which comes into our billing aspect. But it's possible, like if they're in some kind of large building with a lot of different services, they called somebody in to help them. Either way, you will see in the end. So with all CPT services, we use the code that's most descriptive of the procedure performed. Now, we talked about this a little bit with the preventative and diagnostic. Or a lot of times they go in to do a scope just to see, and then they go, okay, great, now we need to open them up and do some kind of surgery. You're not billing for that small scope, you're billing for the more inclusive procedure, the most prevalent procedure given that day, which would be opening them up and doing whatever they needed to do. So in this case, the patient was in pain with their leg fracture, not the cast. The cast isn't giving them the pain. The leg fracture is, that's required manipulation or reduction. The doctor's gonna do a little bit of twisting and turning there in order to set those bones straight prior to putting a cast on it. So the two codes they gave us were 01462 and 01490. They're both anesthesia codes. The 01462 is anesthesia for a closed procedure of the lower leg, foot, or ankle. And the 01490 is anesthesia for a lower leg cast application, removal, or repair. Our most prevalent procedure here, and the patient has pain because of that fracture, he's going to reduce that fracture and manipulate it. So that is our more prevalent code. So we do the 01462. So just for fun, because I got to the answer so quickly, I decided that we're gonna go ahead and code the whole rest of this note. So we don't know a whole lot of information, so I'm gonna make a little bit of assumptions here, just because this is what the field that I'm familiar with. So the provider would also most likely document that additional evaluation and management for that severe sprain of the wrist. So they saw them, they got the history, the HPI, they did an examination of the leg, and they probably could tell right away, needed to be repaired. It wasn't sticking through. It's a closed fracture, so it's not poking through the skin. And that would be an open fracture. So, but there's something wrong with the wrist as well. Well, we need to do an examination there. We need to figure, make a medical decision making regarding the wrist too. So they would most likely be documenting all a separate E&M charge. It's on the same date. So we have an E&M on the same date as a procedure. Again, I'm going to jump back to that modifier 25, a significantly separately identifiable E&M on the same day as a procedure. So they're most likely going to code 27752, which is a closed treatment of a tibial shaft fracture with or without the fibula fracture with manipulation. They have to reduce it, so they have to manipulate it, and that's with or without a skeletal traction. Now, they came to the office. This is right when it happened. We have to take x-rays. So we have a 73590, a radiological exam, tib, fib, 2 views. It's the only code option to choose. Our diagnosis is going to be an unspecified fracture of the shaft of the tibia left, initial encounter. It's the first time we're seeing them. We use that A for initial encounter, and then an unspecified fracture of the shaft of the fibula left, initial encounter. We can do that office visit. I'm going to make a little assumption. We'll just do a 99202, just kind of its minimal decision making here because it's just a sprain. So they're probably going to put a brace around it or something like that. And I'm going to assume they're new. So an office visit new with a 25 modifier. It needs to have that modifier on there because it's the same day as a procedure. And we want to make sure we're paid for both things that we saw the patient for that day. Well, we're probably going to have to take an x-ray of that wrist too and make sure that didn't break, make sure there's no fracture there. So 73100 wrist, you do have an option of 2 view or 3 view. I just picked 2 view. And then our diagnosis code is going to be an S63.501A, an unspecified sprain of the right wrist, and it's our initial encounter. Now, our procedure code that we had for the anesthesiologist, whether they're in the same practice or not, same tax ID or not, you can bill for that anesthesia code, the 01462, along with the orthopedics providers problem was on a separate claim, but they don't run up against an NCCI edit. You are able to bill the anesthesia as and the global fracture care code as well.
That is a lot of fun. I like how you did that and gave them a whole scenario so they could see all of the codes. Yeah. Because we really needed some ICD codes, let me tell you.
That's what we would do. Yeah, we didn't have any. Yeah.
No. Oh. I was feeling a little, usually if I do anything, it's very heavy in ICD. All right, moving on. Hey, yeah, that's right. I'll go through withdrawal without my ICD. Are you a member of the CCO Club? And I'm going to go ahead and not forget to launch this. Your choices is yes, no, I decided not to join at this point, up to this point, or no, I didn't know about it. Is it important? And one of the things that I'd like to tell you is I was just kind of reminiscing that, when we started doing these, we used to get almost 1,000 people on these webinars, and we would give free CEUs, and we had to charge like $5 and stuff like that. And then we were giving out all these CEUs and things. But now we have less people that attend, but it's completely free content. And so you know, we would appreciate it if you would share and let your friends know that they can send in scenarios like that one that Jennifer just did. We'd be more than happy to do research, and it's fun for us. But if you are a member of the club, that's another place where you can do the same thing, and it may or may not be a webinar. Okay, so we are at 70%. I'm going to close this poll. 5, 4, 3, 2, 1, and close. Over 70%. Yes, 45% of you are a part of the club. You know, that's fabulous. That's wonderful. We have a lot of fun in the club. And 33, no, I decided not to join up to this point. So you may decide after tonight. Or 21%, no, I didn't even know about it. Is it important? Yeah, because if you're a part of the club, then you get to keep all the slide decks and answer sheets and stuff like that. Plus you can ask us questions. Everybody always has billing questions, and Jennifer's in her busy schedule. She's always in
I
there
love
answering
those.
questions. Yeah, she likes it because she probably knows the answer off the top of her head. I like ICD stuff, guys. So just moving along here, if you want CEUs, we've got a lot of CEUs in the CCO club, and I don't know our total count.
Stop
We
the share if you don't mind.
do
You
what?
gotta hide the share.
Oh,
You're still
sorry.
showing the survey stuff.
Oh, man, I'm not very good at this, Boyd.
You're
I
doing
have to be
great.
told. I clicked it. Did it hide?
No, is it
Okay,
still?
let me click it again.
There you go.
There you go.
There. Oh, maybe I just need to double click it. Okay, so here's where it talks about all the additional things you can get in the club. You get to earn CEUs, which we all need CEUs, and we have a lot in there. Webinar and support call replays. So say you didn't, you remembered this, what Jennifer just talked about the coding, the fracture and the manipulation and the anesthesia, and it's been 2 weeks, and you say, oh, I remember Jennifer said something about that. I want to go back and listen to her again. Then you just go back and listen to a replay of it. But you don't get access to that unless you're in the club. Billing and coding Q&A questions, like I said, in the forums, and the extended product support that you get when you purchase products with us. It's really easy to find more information than that on the club at cco.us/club. Super, super simple to find it. And I hope that you will tell everybody about it and join us on the club. This is our last question. Yay, it's me. So the question came in that we about class 2 obesity and comorbidities. So we had a patient, that 69-year-old patient has a BMI of 38.23 with comorbidities of hypertension and diabetes. Document says patient is obese and recommends exercise. And so this is what we're thinking. It says they recommended exercise. The physician said they have class 2 obesity with comorbidities. SNOMED stated that if you code class 2 obesity with comorbidities, it's not E66.01, but E11.9. So she's wanting to find, where do I find the tangible evidence that we can code E66.01 for class 2 obesity with comorbidities? And can the physician code severe obesity with comorbidities with documentation of BMI of 40 plus? The answer to that is yes. Okay, so what I did was I took these two codes, the E11.9, which is right after hypertension that most new coders memorize. You don't have to memorize codes, but you just see it so often that I-10 is hypertension and E11.9 is type 2 diabetes. And then the code that she was talking about, the E66.01, morbid or severe obesity due to excessive calories. Okay, that's pertinent right there, due to excessive calories. Now, we know that obesity can lead to diabetes, but what you have to think about here is that but diabetes doesn't cause obesity. Obesity can cause diabetes, Obesity can cause hypertension, but hypertension doesn't cause obesity, and diabetes doesn't cause obesity. Okay, you got to think of that first when you think of the disease process, because that makes a difference in the way that you code it. Now, E66.01 is obesity due to excessive calories, not due to diabetes. All right, so there's not a causal relationship there. However, if the provider wants to say there's a causal relationship, there is a way to code that via the diabetes. But the short answer is no, you don't code E66.01 in the way that you're thinking. But obesity does cause higher risk in the things that the patient stated to have, as well as the heart disease, stroke, arthritis, and even some cancers have been linked. So let's look at the BMI real quick. So if you want to know the breakdown of the BMI, and you don't have to have this memorized because it's all over the place, but you're overweight if your BMI is 25.0 to 29.9. And honestly, that's a pretty low BMI. But you're obese if you're 30.0 to 39.9, and you're morbidly obese at a BMI of 40. The kicker here, though, is if you want to use a BMI code, you have to have a diagnosis of obesity in the documentation. You cannot code a BMI alone. You will always code a BMI with an obesity code. Okay, you can't. You can code obesity without the BMI, but you can't code a BMI without the obesity code. It has to be documented, right? And that is something that you'll be tested on if you guys are students. Make sure you make a note of that. Also, I just went ahead and added this because it's kind of pertinent. A lot of times people that have obesity have breathing problems, and it's documented, and you forget that it needs to be coded as well. All right, and that was actually in some of the guidelines, so I thought I'd add that there where it's applicable. Now, again, the key here is obesity is not a side effect of diabetes, all right? And nor does hypertension cause obesity. But a person that has obesity is at high risk of diabetes and is at a much higher risk for hypertension, right? And why are we coding to begin with? It's to collect the statistics on the disease process. So when we go back to say, okay, well, how do I code this then? Then we have to think, okay, we're coding for statistical purposes. So that's important. Now, we all know that BMI is calculated via weight and height. I went ahead and added that if anybody needed to know. And you may have asked yourself if you weren't familiar with obesity class 1, 2, or 3. What are the guidelines, or what signifies class 1, 2, or 3? And it is a class 2 means you're at moderate risk, but class 2 is obesity with a BMI of 35.0 to 39.9. And our patient that was stated is a class 2. The BMI shows that. Okay, so if you have documentation by the provider that says that they are, have class 2 obesity, that's what they're referring to. Right. Now we're moving down here real quick. Now that we know all of that, she mentioned SNOMED, and she was saying SNOMED said that with this scenario, it's coding E11.9, not E66, right? Well, there's a reason why SNOMED does that. SNOMED is actually it's a program, and it stands for Systemized Nomenclature of Medicine Clinical Terms. It's standardized. It is a program that lets the provider do an electronic exchange of health information. So SNOMED is saying, no, you're going to code. It's not saying that it replaces the code, all right? because that's kind of the way I got the impression she was saying. They're saying we don't code the diabetes, we code, I want to code E6601, and they're saying, no, you're supposed to code E11.9. Well, the fact is you're coding both, okay? It doesn't replace it. It's saying if you have to pick out of your diagnosis that you inputted into SNOMED, and it doesn't matter what order you put them in. So you said, okay, we got a class 2 obesity, we have hypertension, and we have diabetes. Okay, and SNOMED is saying, no, you don't code E6601, you need to code E11.9. They're saying your primary code, the first listed code that you're dealing with, is diabetes. Okay, the patient has diabetes and the patient has E6601, obesity, class 2, right? And that BMI. And in addition, if you want to code the BMI, it's Z68.38. Okay. So those 3 codes capture. It's not saying that you're replacing E11.9 with E6601. It's saying, no, the patient's an E11.9 and they're an I-10, they have hypertension, and they're obese, and they have a BMI of, okay? So there's actually 4 codes there. I was skipping the I-10. Now, if you want to change that up, say that there's more content in the description than they provided in asking the question, then what you're saying is that, okay, our provider said that the obesity is a complication of the diabetes. Now, we may not be able to wrap our mind around that, but the fact is the provider can say that. You know, it's not up to us. And if the provider, you query the provider and you say, you know, from what I'm reading here, I got the impression that you're saying that obesity is, you know, due to the diabetes, or that it is a comorbidity of the diabetes, just like the hypertension. Okay, so what, you know, let me make sure I understand this correctly. There are a couple options with the diabetes to give us a statistic to capture that. And your options are, if the patient has diabetes and it has an other specified complication, right? Other specified complication that is not, doesn't have a code for it. So there is not a diabetic code with a complication of diabetes. There just isn't one. But he said, no, there's a causal relationship there, and I want you to capture that. Then you could use E11.69. It's an other specified, right? Now, maybe the provider describes it and it ends up being an unspecified complication, and that would be an E11.8. So they're saying that the documentation is telling us it has the presence of a complication, the obesity, but it's undefined or general, just obesity, right? Okay, then you could use E11.8. Or if it's just without complication, so he's saying, no, I want you to, we need to capture that the patient is obese and they have a BMI because they're, and it establishes that they're a class 2, but they're diabetic and they have hypertension. So these are all separate. I'm not putting them together. Then you got your E11.9. The best thing to do is to let the provider see these choices for the diabetes, okay, right here, and say, is the weight a complication of the diabetes? And these are the code choices that I have. Which one are you telling me that it is? And then the provider gets to circle or tell you which one it is. And they can choose. It's not up to us. We translate for them. Maybe they don't realize that these other 2 options of E11.69 or E11.8 exist. And so therefore you tell them in the future, if this is a complication, then just add that verbiage in there that the weight is a complication of, the key word, magic word is complication of the diabetes. And then I can pick the highest specificity for you, and we can get the correct thing captured. Okay, so ultimately, though, SNOMED's not telling you not to use E66. It's just saying, no, the patient's an E11.9. They're diabetic. The other things just happen to comorbidity is not necessarily the term. In addition to being diabetic, they have hypertension and they have obesity with a higher specificity of their actual BMI. That's it. See, now that's my fun stuff. That's the ICD stuff, right?
Do you just see the wheels turning when she does that and the excitement come to her face?
Yeah, this is what I enjoy. All right, so we have a survey that we would really appreciate that you guys take. It will help us better serve you, and that's at cco.pe/QA201908. You can take that at any time, but it helps us. Again, we want to give you the information that's going to be beneficial to you. Otherwise, I'm only going to teach you ICD-10. If I have, and Jennifer's only going to talk about billing, but again, let us know what you need, and we want to provide that for you. So it'd be great if you do that. Boyd, we're ready to pick a winner. I think we're doing good on our time. Oh, shoot, I may have talked a little too long. And you can either pick as the winner the Blitz video package or a year of the CCO Club Basic, which is awesome, and or a 1-hour session with me or Jennifer. Although really the best value, I mean, you can pick anything you want, but a year of the CCO Club Basic is a great way. You'll be able to capture us in the forums, so not just for an hour. So anyway, you get to choose. Did we get a winner, Boyd?
We did, and you can hear me right. I've been silent for so long. I'm going to butcher her name, I'm afraid of, but it's Joanna Rivandenaria, I believe, Joanna. So Johanna, I'm sorry. So I'm gonna put that into the chat here for everybody so they can congratulate her.
Hey, Johanna.
And you have a choice of contacting the help desk, right, and choosing one of these things that are on the screen. So you can write us a ticket, or you can email helpdesk@cco.us, but we preferred if you just go over to the contact us section and let us know that you want to claim your prize, and we'll get you hooked up.
Yep. Thank you very much for joining us. And let's see, there are up to 80 CEUs in the club. So again, that is the site. If you want to go directly to the club, you can go to cco.us and find the club information, find it there, or you can just go to cco.us/club. And again, these are CEUs that are fun, they're exciting, and they're pertinent to what you're either studying to pass an exam, or you are wanting more information and maybe in cardiology or billing or something, or even orthopedics. We have specialty CEUs as well. Being a part of club, you can have access to that. So now we're ready for our chats, and I'm going to bring that over. Normally I try to get in there and talk a little bit in the chat, but my internet isn't all that great right now, so I didn't get in there. But Sylvia and Lori were in the background. So for August 2019, and mind you guys, the webinar is officially over. Okay, so if you want to leave us, you can, or you can stay and see if you want more information. Okay, so what is the key to knowing when to use a CPT code or a HCPCS level 2 code? Oh, I know Jennifer knows the answer to this off the top of her head, because this honestly is more of a billing question. I know that Jennifer teaches at a college too, but sometimes the students get frustrated because they say, well, you didn't talk hardly any at all about the HCPCS books, HCPCS manual and how to use it, and I've got to use that for the test. Well, the fact is so similar to the CPT, and it's very minute. There's only 5 questions on the CPC exam, but take it away, Jennifer. Tell them.
Full screen for me, please.
Full screen? Okay, hold on.
Thanks.
The biggest difference is Medicare will mainly use your HCPCS book. So the HCPCS codes typically are going to relay if there is a similar HCPCS and CPT code. If it's a Medicare patient, they're going to use the HCPCS code versus the CPT. So a lot of people, and I do get that all the time, well, how am I supposed to know that? That's your tricky question. A 67-year-old patient or a 75-year-old patient had a colonoscopy performed, screening colonoscopy. Well, that's the G code then, not the 43580, or yeah, I think that's the code. So you're looking mainly for your Medicare if there's a CPT and HCPCS code that are similar. They usually will default to this HCPCS code for Medicare patients. So
yeah, and it's if you're worried about testing versus real world, they're blatant. They tell you this is a Medicare patient, da 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 da, and then HCPCS.
Yep. Yeah. So and they'll give you 2 CPT and 2 HCPCS. So then you gotta, oh, okay, they're trying to trip me up here. So
they want to know if you know. That's how you do it.
And in the real world, you just go look on the site and see what they want to use versus, in a test, that's their trick.
Yeah.
But in the real world, you just go to CMS, Medicare, and they'll tell you. Yeah.
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 Will an insurance deny 82962 if it was a QW modifier added, or is this modifier appropriate for in certain circumstances? Well, there you go. Jennifer knows that too.
I looked it up.
Oh, okay. I was going to say, she probably
No,
knew
I
it.
wanted to be prepared. I think I've talked about this before when dealing with a lab code, but I did look it up. So again, we're talking about Medicare. There is, for Palmetto had an answer on here. Palmetto GBA is the Medicare carrier for a lot of the southern states. For the CLIA test, there's waived CLIA amendment list. So there's a waived list. And a QW modifier, let's see here, determines which lab tests are waived. And not all CLIA waived tests require that QW to indicate that it is a waived test. So the CLIA waived procedures do not require the QW modifier on 1, 2, 3, about a dozen codes, and one of them is 82962. So that QW is not required on the 82962. So that's on Palmetto GBA. Just Google, or go to their search and do QW modifier, and it will come up with that, or 82962. It will give you that information for your CLIA wave test. So
that's another thing about the clubs. If you run into scenarios like this and you just need a source or a resource, ask, because this is something that's real easy for us to provide. And again, that's just, we want to be there for your resource. So make it easier. Okay, next question. What time frame should you study for the CPC test so you're not crammed with everything? Well, if you get the CPC Blitz, that is
a week.
Yeah.
I think that was
really hard
exceptional.
to get the CPC Blitz done in a week.
I think that was exceptional for Sandra. But
wow. Yeah, that means she was committed. In other words, we want to nicely say is Sandra doesn't have a life. No. Obviously,
she took her vacation. That's what she
there
did.
You go. Oh, that sounds much better. Sandra doesn't have a life. She could take a whole week and get that done. But on average, it takes about 2 weeks. It's about 80 hours of, is it 80 hours of lecture? I can't remember what it was. Even if you don't watch the videos in the Blitz and you just bat your CPT manual, I mean, that's that takes time, but it can be done in increments, and once you get the hang of doing it, it's not like you're looking at something and doing it real, and page by page. No, it's a technique that you're learning.
I do want to clarify something here. So what time frame should you study for the CPC? Is this somebody who says, I want to be a coder, and they're going to take CPT tests? You're talking 4, 5, 6 months now. Yeah, typically 16 weeks is typical a time. But if it's knowledge you have, or maybe you took a college course 2, 3 years ago, or you did some AAPC study a couple of years ago and you just never completed it, then you're looking at maybe your 2 weeks. But yeah, you don't want to cram. You want to take your time, and definitely not the day before. You don't do anything the day before.
No, that's in the Blitz, tell you.
You relax, you take a bath, you do get your nails done, whatever.
Right. And you want them to be nice and pretty when you're bubbling in those. If you take and a HEMA too. A HEMA's test is online, and the AAPC's tests are all paper. So it does make a difference, and not just for the CPC test, whatever type of coding credential you're going for. But we usually tell people it really depends what your background was, like Jennifer said. On average, if you are very committed and you don't have a lot of, you're not a caregiver, you don't have children or taking care of a parent, or full-time job, things like that, 4 months is doable. But I would give myself 6 to 8. For you don't know, you could be on a skateboard and break your tibia and fibia, and you're going to be out.
And your wrist, you can't turn the pages, so
That's right. And you have to consider a few things too, like when are you starting? Are you going to have Christmas vacation? You got like, if you're going to start in the fall, you got some major holidays that might interrupt your study time. It's still wonderful to study in the fall. Because if you're working, you usually have a little vacation time for your studying and stuff. But you have to think about, you're not going to be able to study if you have all your family over for Thanksgiving. So,
I know a lot of people try, and especially this time of the year, it's August, September, you're thinking, oh my gosh, I got to take that test by the end of the year so I don't have to buy new books.
Right.
Well, make sure you have plenty of time to study, and it takes 8 weeks to schedule your exam, remember, like 4 weeks. You need to schedule your exam prior as well, and schedule that follow-up exam just in case. So you need some time to lay that out too. But tip, don't stress yourself out, because they will change the tests in 2020. Yeah, that's the next year. Yeah, 2020. So they will change the test, not January, February timeframe. Not too many chapters offer exams in January, especially if they're in snow states or something. But you can still use a 2019 book in 2020. You can.
For a month.
You may not. You may miss some answers because they might throw a new guideline or a new code out there, so you might miss that one. But that's the risk you take. But you can. So don't let somebody tell you can't. You got to get it done.
We tell people not to do that. If you're asking our opinion, we would say, don't. Because a lot of people miss the exam by 6. They get a 68 instead of a 70. So that means that question, because you didn't have updated manuals, do you want to take that risk?
That's your one.
However, like Jennifer said, you could use a 2017 if you want. They won't tell you no. They shouldn't, but as far as the AAPC is concerned, they don't care. However, why would you do that to yourself? You're paying a lot of money. Anyway, so that's a good question. Oh, I think that's the last one, right?
Yep. They did 3.
You guys are awesome. So just to update guys, we are on YouTube. During the week, we live stream on YouTube and Facebook. And I think we're going to start live streaming on LinkedIn. Boyd was talking about that this week. It'll be something new for us. But if you want to find us on YouTube, Medical Coding Cert, we have over 1,200 videos in there, and we have almost 2,500 subscribers. Over 3 million views. All you do is hit that subscribe, and next to the subscribe now there's a bell. If you click that bell, and you can change that at any time, it'll give you a little shout out whenever we're going live. So that's kind of nice. And we do this by word of mouth. So you can go in and find lots of content, share them with your friends. Facebook is different than YouTube. We still stream live. Go in and feel free to share our content in Facebook. All you have to do is go in and like us there, and it's easy to find, cco.com/cco.us on Facebook. If you are interested in having a remote presentation, we've been doing that for a couple of years now. Here are some topics that we've been doing for a while. We just added the 2020 ICD-10 updates, CM updates, and we'd be more than happy to do a presentation for you. If you want a live presentation where we physically come to you, you can do this. You can go in and ask, in addition, remote presentation or live. But I'm in Texas, and I'll travel anywhere in Texas. Jennifer is on the East Coast up in, I started to say Maine. You're not in Maine.
No.
She's outside DC, a little ways outside of DC.
Maryland.
So
Yeah.
Maryland, there's a lot of, she could go the same distance I go in Texas, and she can be in 3 different states. That's very cool. But feel free to ask us, because it's kind of hard to find live presenters, but if we can drive, we're more than happy to do that for you. Plus, we enjoy seeing you and seeing your faces and getting pictures and stuff like that. It's a lot of fun. So go to cco.us/remote-presentation, and Lori sets those up for us. Maybe there's a topic that you don't see here that you'd like to have. I'm going to do one on risk adjustment CMS versus HHS coding, and add that one. So all right, don't forget to take that survey for us. It's really, really helpful. And don't forget to go to the CCO Club. If you go here to this the cco.us/club, you can get more information. There's FAQs there for you. Here is all of our links. That testimony that the testimonial page that Boyd mentioned is linked here. And you know what, it is really, it says a lot about our clientele, our friends at CCO that use our products when they, we always have current testimonials, and we really appreciate that. Thank you for doing that for us, because it tells people that are just inquiring that we are real. We're not just out to get your money, and we try really hard to give you affordable education that's pertinent to what you need in your life. So anything?
Forget about the back to school sale that's expiring tomorrow night, I believe at midnight.
Yeah.
So
Tomorrow,
yep, just go to cco.us. You can find out all about that. It's right at the top, and you can click right there and find out more about it.
Yep. All right. So happy learning, guys. You're still a lot of us with you. I think that's my last slide. Yep. It is.
Yep.
So
It is.
go out
Thanks
to the
for being with
club.
us.
Let us know that you enjoyed, if you enjoyed it, and the topic requests, so we can get ready for next month, September. Woo!
So good night, everybody. And until next month in our monthly Q&A webinar, sign up, go back to cco.us and sign up for next month's webinar. We'd love to see you again. And don't be afraid to put in a question too, that you've been bugging you and keeping you up at night, or maybe help you get the next job, or keep the next job that you've already got.
That's right.
All that kind of stuff, right? We're here to help.
Or ask us what you think the next credential you should get is. Yeah, that would be a good one too.
New poll idea. There you go. All right. Good night, guys.
Bye. you.